Answer, answer.
Please pay attention. It starts from the foundation. Everybody needs somebody. Everybody needs some love. You turn a blind eye and care nothing less. Say it's just business, all about the money. You are so unbothered as long as they pay. Say it's just business, all about the money. You know they're on a fast lane, but you've got business to run. So you look away the other way. It concerns you. You dey kill love, you dey kill dreams. You dey land people for jail. War against drug abuse.
I was the head boy in my primary school, senior prefect and best graduating student in my secondary school, but drug abuse almost ruined my life.
I was on an average of 2 grams of cocaine per day.
I was taking 8 ampoules of pentazosine daily.
European shisha, cocaine.
I became a user, a dealer, and a gangster.
I saw other users drowning. I knew I didn't want to be like them, but I was already trapped.
My family disowned me.
My employment was terminated.
I sold my car, sold my house. I'll go out well-dressed and return shoeless, shirtless in exchange for drugs.
I was seeing things that were not real, and I once stabbed myself because I felt something crawling under my skin.
I contacted NDLEA and started therapy.
I spent 3 months in therapy.
I spent 8 months.
It's easy to relapse, but your mind has to be stronger than the cravings.
Drugs does not love you. You are not the one using drugs. Drugs are the one using you. Say no to drug abuse.
Hello, doctor. Can I get the tramadol for the road? Body they pay me
wait to make I check your body, then I go tell you wait till you need.
Hello, doctor. I know it's the way to wait. I know it's the way to
wait to make I check your body, then I go tell you wait till you need.
Hello, doctor. No need to check me. I know say now waiting my body need. Is it your body?
Wait to make I check your body, then I go tell you wait till
I don't be wait. Hello, doctor. You see I am coming. I need to deal. I go enter coffin.
Wait to make I check your body, then I go tell you wait till you need.
Give me cannabis, please. I need to end this feeling.
Wait to make I check your body, then I go tell you wait till you need.
Hello, doctor, waiting I do myself. I've been on the same, but I didn't want somebody.
Wait to make I check your body, then I go tell you wait till you need.
Doctor, help me check my body. I need your help before it's too late. Hi.
Asia, Middle East, and other parts of Africa. Thank you very much for believing in our conversations and for always being part of this process of engagement. This is a platform reintegration back into the society. It is equally a means for us to update you about how the activities of the agency, especially what we're doing to curb the scourge of substance abuse and illicit drug trafficking, as well as getting your feedback so that we can continue to deliver better services, and serve the society and humanity better. Would like to also tell you that this conversation is recorded and is streamed live on our other social media handles. That is at NDLA01 on Facebook and at NDLA underscore Nigeria on YouTube, in addition to um, this channel that is X Space, where we are reaching you live from the NDLA's national headquarters here in Abuja. You can always go back and listen to the recording. You can even share with others. All of these are available immediately after the program, that is in another 2 hours. We already have our guest well seated, and I can tell you that this is not going to be a dull moment with our guest today. And we'll be looking together with him, we'll be looking at the efficacy of transcranial magnetic stimulation in drug addiction and mental health treatment. Our guest today, I'll tell you, he's someone that has a deep knowledge about this particular special area, that is TMS. And should I unveil him or yet? But then before I unveil him, let me also tell you that indeed I'll be your host today, your regular host, Femi Baba Femi. So just stay with us, share the link with others, and let's share knowledge, let's share information, let's benefit from the depth of knowledge and experience of this great Nigerian, especially as regards the use of transcranial magnetic stimulation in the treatment of drug addiction and mental health. Before I invite him to make his presentation, let's try and update you or remind you about some of the activities of the agency in the past week in our news highlight segment, which will be taken in a moment by our regular Blessing Tafa. Blessing, we're ready for your updates. Please go ahead.
Thank you, sir. Good day to everyone, and thank you for joining us on this week's X Space. My name is Blessing Tarfa. Here are the NDLEA news highlights for the week. NDLEA uncovers meth opioid consignments in jeans, hems, dolls, buttons. NAB's drug kingpin in Lagos hotel recovers 8 tons of cannabis, 8,000 bottles of codeine in Edo, Delta, Bauchi, FCT, Kaduna, Gombe, Kogi raids. Crooked attempts by drug syndicates to export illicit substances, including various quantities of methamphetamine and opioids concealed in hems of new jeans trousers, dolls, buttons, local soap, and tins of Milo beverage to Europe, United Arab Emirates, and Asia have been thwarted by operatives of the National Drug Law Enforcement Agency, NDLEA, at some courier firms in Lagos. Some of the consignments intercepted by the NDLEA operatives of the Directorate of Operations and General Investigation, DOGI, at courier houses in Lagos include tramadol 225 milligrams concealed in hems of new jeans trousers heading to Cyprus, shipment of cannabis sativa hidden in the heads of dolls going to Dubai, UAE, sachets of tramadol 225 milligrams buried in tins of Milo beverage going to UAE, and another set of same drug hidden in local soap also going to UAE, as well as a consignment of methamphetamine concealed in buttons heading to Hong Kong. A shipment of another illicit substance coming from Florida, USA, was equally intercepted at a courier firm, while the recipient, Daniel Ogi, was tracked by NDLEA officers and arrested at 5 Akim Shitu Street, Ajao Estate, Lagos, on Friday, 24 November 2023. Operatives in Lagos on Friday, 1st December, also arrested a drug kingpin, Okechukwu Ogala, 56, who specializes in exploiting and recruiting young citizens to export meth to Asian countries. He was arrested at Blue Moon Hotel in Okota area of Lagos with 60 wraps of methamphetamine weighing 1.009 kilograms. In another operation in Lagos, operatives on Friday, 1st December, recovered 393 kilograms of cannabis in a shop at Akala Mushin, while a suspect, Justin Onioye, who deals in Canadian loud, was arrested by the police at Victoria Island and transferred to Lagos Command of NDLEA on Friday, 1st December, with 154 parcels weighing 92 kilograms. A team of NDLA operatives also intercepted a vehicle at Oyibo area of Lagos and recovered 108 kilograms of cannabis from it, while 675 kilograms of the same substance were recovered from the store of a wanted dealer, Wahab Olota, at Adedoja area of Mushin, Lagos. In Edo, NDLA operatives on Wednesday, 29 November, stormed the Ujiogba Forest, Eshan West local government area, where they recovered 5,988 kilograms of cannabis already processed and ready for distribution, while a 22-year-old Nson Bunde, also known as Tete Peter Joseph, found in a hut on the cannabis farm, was arrested. No less than 120,000 capsules of tramadol concealed in new sound systems packed in a Jos Plateau State-bound bus were seized by NDLA officers acting on intelligence along Onitsha-Okka Road, Anambra State, on Monday, 27 November. While 120 blocks of cannabis weighing 73 kilograms were recovered from a suspect, Abdullahi Mohammed Bello, along Gombe Bauchi Road, Gombe State, on Wednesday, 29 November. Operatives in Abuja seized 168 blocks of same psychoactive substance with a total weight of 101 kilograms from the store of a fleeing drug dealer in Kabusa area of the FCT. No fewer than 8,000 bottles of codeine syrup were recovered by NDLA operatives on Friday, 1st December, when they intercepted a vehicle transporting the opioid along Abuja-Kaduna Road, with the driver Shamsu Isiaku and his conductor Muhammad Maina arrested. Same day, operatives also arrested Ernest SCHA 30 with 44.4 kilograms of compressed cannabis sativa along Gwantu Sanga Road, Kaduna. In Kogi, NDLA officers arrested Ahmad Umar 18 with 46.4 kilograms cannabis at a checkpoint in Kaba, while Jamilu Zakari 32 was nabbed at Kofar Idi, Kandahar, Bauchi Town, Bauchi State, with 125 blocks of same substance that weighed 146 kilograms. At least 542.3 kilograms of cannabis were recovered from a suspect, Festus Egioguli, 32, when his base at Jakpa Road, Warri, Delta State was raided by NDLA operatives on Wednesday, 29 November, while 125.9 kilograms of same substance were also seized from a store in the same area. While commending the officers and men of the Lagos, Edo, Anambra, Gombe, FCT, Kaduna, Kogi, Bauchi, and Delta commands of the agency, as well as Dogi, for their outstanding feats in the past week, the Chairman Chief Executive Officer of the NDLEA, Brigadier General Mohammed Bubamora, retired, equally applauded their counterparts in all the commands across the country for intensifying their WADA advocacy lectures, thus creating parity between their drug supply reduction and drug demand reduction activities. That's it on arrests and seizures. Now, here are the WADA activities across the country for the week. The NDLEA War Against Drug Abuse WADA initiative has been employed nationwide as an effective tool to reduce the demand for drugs by the society. This week, commands across the country were all out to equip youths and school children with the skills to avoid behaviors that make them predisposed to drug abuse. On Monday, 27 November 2023, the Osun State Command delivered a WADA sensitization lecture at the Apostolic High School, Ilesha. The Rivers State Command on Tuesday, 28 November, facilitated a WADA sensitization lecture to students at Unibec Group of Schools, Port Harcourt, and the Kano State Command on the same Tuesday organized a WADA sensitization lecture for students of Taskar Al-Khairi Primary and Secondary Schools, Gobrawa, Dala Local Government Area, as well as the pupils and students of Natsuguni Primary and Secondary Schools, Ungogo Local Government Area. Continuing the WADA sensitization visits for the week on Thursday, 30th November, was the Enugu State Command at Army Day Secondary School, Akuke, the Ondo State Command at Kev Queen College, Itanla, Odo West Local Government Area, and the Anambra State Command at Pranters School, Oka. On Friday, 1st December, the Seme Special Area Command delivered a WADA sensitization lecture at King Stars College, Aradogun, Badagry, while the Borno State Command delivered a similar lecture to students and teachers at Usman Jidda Shua Memorial Secondary School, Gamburu. That's the update for this week. My name is Blessing, and I hand you over to our host, Mr. Femi Babafemi.
Thank you very much, dear Blessing, and welcome back from the News Highlight segment. And I'd like to remind ourselves about some of the rules guiding our engagement on this program today. Please When we approve you to be on the speaker scanner, please ensure that you remain muted until our guest presentation. I will start inviting individuals to unmute themselves and make their contributions or ask their questions in few seconds. Please emphasis on few seconds. Let's try as much as possible to make our contributions very brief so that we can have enough time to take contributions from others. Again, we'd like to remind us that we don't encourage unauthorized interruption. You can only speak when I ask you or invite you to unmute yourself and speak. That's the procedure here. And again, please note that we don't discuss politics here. We're strictly discussing on something that affects the society and our public health, and that is the issue of substance abuse and illicit drug trafficking. That's basically our focus on this platform. We like to educate people, we like to raise awareness. That's what we're doing here. So please let's all remain guided so that we can enjoy and benefit from the conversation. Would like to appreciate you for your usual cooperation by taking to all of these guidelines. Thank you very much for that. Notwithstanding, we try to make our conversation here as interactive as possible. We will try to respond to all your questions, take your contributions, especially on today's subject of discussion. So please let's stay calm and enjoy the conversation. But before I invite our guest speaker, let's quickly remind us about the NDLA call center. That is a platform that the agency has provided for those struggling with substance abuse, their friends, their families, to get some help. There at the center, we have professionals, we have counselors, we have psychologists, we have psychotherapists, as well as psychiatric doctors, and a host of other mental health experts who are always willing 24/7 to speak with you, to pick your call. So we have a dedicated toll-free helpline there. You don't need to pay for the call. Just dial the number 0800 1020 3040. I repeat again, that is 0800 1020 3040. Just call this number from any part of Nigeria, any part of the world, wherever you may be. Just dial the number and you have our experts ready at any time of the day, at any hour of the day, wherever you may be from. Please dial this number. If you think you, your family member, or your friend need help, please call this number. Our experts will be ready and willing to assist you, to guide you, to counsel you, and put you through a treatment plan or a process. And you would definitely be glad you did. Again, I would also like to tell you that you can access this service either in English, Pidgin, Hausa, Yoruba, or Igbo. Please, there is no that. What that means is you have really no excuse to say you are not taking advantage of this opportunity to get help for yourself or for your loved one. Thank you very much. That's on the call center where we provide teletherapy and much more to those who need support. Now, let's formally introduce our guest today. He is Dr. Bukola Williams. He is a mental health physician, a certified addiction professional, and transcranial magnetic stimulation application specialist. His work in the use of transcranial Nigeria, any part of the world, wherever you may be, just on the call center where we provide teletherapy and much. Owner of the Royal College of Psychiatrists, United Kingdom, and also published by the World Congress of the International Neuromodulation Society, often called DBW. That's Dr. Bukola Williams. That's he is passionate about mental health advocacy as well as supporting people with substance use disorders and mental illnesses. He's an author, public speaker, and business enthusiast. And he went ahead. He equally had obtained an MBA, that's Master Business Administration with specialization in finance and investment. So, ladies and gentlemen, please join me to welcome as I invite Dr. Bukola Williams to unmute himself and make his presentation. Please, apologies those already were seated. I'll definitely, after his presentation, before we start taking your contributions, I'll definitely recognize a whole lot of you. Thank you very much, Dr. Bukola. Please, you can go ahead now.
Thank you very much, Mr. Femi. Good afternoon to you, and good afternoon to everyone on the space. Could you just confirm if you could hear me, please?
We can hear you loud and clear globally because we have several people all across the world already on the platform. Please go ahead.
Thank you very much. Good afternoon from this part of the world. I mean, this is Nigeria, Abuja precisely. And I'm going to be taking you through very quickly on the efficacy of the TMS in regards to treating mental illnesses and substance use disorders. I'm sure I'll be able to take your questions at the end of the presentation. So I'm going to do it this way. I will talk about what the TMS is, and I will talk about its role in treating mental illnesses, and then talk about its place and its potential place in treating addiction. And we all know that there is a connection between substance use disorder, I mean, that's addiction, substance addiction, and also mental illnesses. When people use substances, they can get depressed. Some of the substances that people use are depressants, and some are stimulants. And sometimes when people are withdrawing from substances, they can get depressed. So there is a lot of connection between substance use and mental illnesses. So it's important that we go to town and talk about this topic. Over the years, there has been concerns with regards to the field of mental health, concerns with the fact that medication use, which is the mainstay of treatment, in addition to psychotherapy, may not give, nothing gives 100%, nothing gives 100%. And then with cases of resistance, medication resistance coming up, there were a lot of concerns. What should you do? And also we know for addiction, there is really no medication that you can give. Some medications have been approved lately for the use of substance addiction. But again, the concerns have been there. How do you deal with resistant cases of depression, for example? How do you deal with substance when people have gone in and out of rehabilitation? What should you do? And also, there were concerns about adverse effects, side effects of medication for those who have to use medication. And then came up this new technology, the transcranial magnetic stimulation. It's probably not new in other parts of the world. It's new relatively, but I mean, other parts of the world have embraced this technology, and people have had to do sessions for 10,000 of people using TMS. In fact, there is a center that has done over 200,000 treatment using the TMS. But we are lucky to have this machine in Nigeria, and there are about 2 of it in Nigeria, 1 in Abuja, 1 in Lagos. And this has really brought a new face to our treatment of mental illnesses and addiction. So what is the TMS? And the TMS is a non-invasive technology. We actually regard it as a breakthrough for treatment of mental illnesses and addiction. Now, the principle is simple. For those who are science inclined, the principle is that of electromagnetic induction. Electromagnetic induction. So you know a magnet. When you bring a magnet into a place and there's a metal, there's going to be a reaction. There's usually a magnetic field around a magnet. And so when you now bring that magnetic field close to something that can conduct electricity, there's going to be an interaction. There'll be an interaction between the magnetic field and that thing that can conduct electricity. And this is just the principle that we use for RTMS. Now, our brain I'll try and be simple as much as possible. I will try to avoid using highfalutin words so that I can drive home this presentation. We know that our brain conducts electricity. Our brain has a lot of electrical activities. The brain cells and the brain nerves, the way they carry out their transmission is through electrical activities. Now, the principle is this: you bring a magnetic field close to the brain, and what would you achieve? There'll be electromagnetic induction. The magnetic field will stimulate electrical currents in the brain. And this is just the simple explanation, the simple principle behind the TMS. I need to say it is simple because it's actually simple. And even though we know it's a bit complex, I mean, how this thing works is still being researched. Now, a lot of times people who are not well informed find it difficult to accept this. Now, people have concerns when you are talking about electromagnetism, and then when you now have to talk about the magnetic resonance imaging, which is used in radiology. People are concerned, but the magnetic field that is generated from the TMS is brief. It is not in any way comparable to what is generated by the MRI. So it is safe. It is safe. That's what the TMS is all about. And what is the leverage with the TMS? It is non-invasive. You don't need to inject anything into people's body to use the TMS. You don't need to inject. People don't have to take any medication to make the TMS work. I'll still come to talk about that. It is non-systemic. It doesn't require any form of anesthesia. You don't have to sedate the patient. The patient will remain awake throughout the duration of the treatment. And it also has another advantage. It can treat a wide range of conditions. It can treat a wide range of conditions like we will get to see. And the patient doesn't have to be on admission. This makes it advantageous also. The person who is going to receive the TMS, whether for addiction or for mental illnesses, they don't have to be on admission. In fact, people take their break time to come and have their sessions. We have people who go to work and then they come and they have their sessions. And another advantage is that it's been widely studied, even though research is still ongoing, and it's been FDA approved. It's been FDA approved for some conditions, which we are going to talk about. It's been FDA approved for depression. It's been FDA approved for obsessive compulsive disorder, and it's been FDA approved for migraine. It's been FDA approved for nicotine, for nicotine cessation. That's cigarette cessation, and it has a wide range of use. It has neurological impact. It has both psychology impact. In fact, like Mr. Femi rightly said, we had our first breakthrough using the TMS about 2 years ago, when we successfully used it to treat an elderly patient who presented with severe depression and Parkinson's disease. And we achieved success with this. I'm going to talk about that eventually. So let's look at what the TMS does with depression. With regards to depression, a lot of work has been done. A lot of work has been done with regards to the TMS and depression. And a lot of studies have been done, and a lot of people have been treated. Even for us as a center also, we have managed several people who had depression and who have done well. Studies have shown that when you use TMS to treat depression, it will improve symptoms of depression more than the conventional antidepressants that people use. So you'll find that people use antidepressants, and the efficacy of the average antidepressant is about 40 to 60%. So what happens to the other set of people who will not respond to your conventional antidepressant? Or what happens to people who have intolerable side effects, people who have side effects that cannot, that they can't cope with from medication? That is where the RTMS comes in. And the success rate is about 70 to 80% when you use RTMS to treat people who have depression. Don't forget, I mean, it might not be the first point of call. It might be for someone who has tried 2 or more antidepressants and they are not responding to it. And then you say, oh, this one is treatment failure. I mean, treatment resistance, and then they come in for session. Or for people who are using the antidepressant and they are having side effects. I mean, for example, one of the side effects that comes with using some antidepressant is sexual dysfunction. So we have some of our patients who are using antidepressants and having sexual dysfunction, opting for RTMS because it will save you this kind of side effects. It's very important to know that. So if someone has a diagnosis of major depressive disorder and they want to opt for TMS and say, you see, I don't want to use medication, I don't want to go through the stress of using medication and all of that. Now, they can be offered TMS. And if people have used the traditional medication to treat depression, like 2 to 4 medication trials, they haven't succeeded, they can use TMS. If you are not satisfied with the results you are getting from using medication, you can use the TMS. If you cannot tolerate the side effects from medication, you can use the TMS. And also, if you have any illness that limits your ability to take medication, maybe some metabolic conditions, interactions with other medications, you can use TMS. And if you are now having depression with anxiety symptoms, you can also use TMS. And the results, like I will talk about, is quite very positive. Let me talk about TMS and anxiety. Even though TMS has not been specifically approved for treating anxiety, but again, a lot of times people who have depression have anxiety as symptoms. And what I find in treating people who have depression and anxiety is that the anxiety symptoms improve as their depressive symptoms improve. So you can see that TMS also has its place in the treatment of anxiety. Another condition that we use TMS to treat is what we call the OCD, the what we call obsessive compulsive disorder. Now, the FDA, the Food and Drug Administration in the US, approved TMS for treatment of OCD way back in 2018. And the result is like you get when you use it to treat depression. People with, you know that people with OCD, they usually, when you look at the brain, they have increased activity between what we call the prefrontal cortex and the striatum. So, and once this activity is increased and there is a connection, there is an hyperconnection that exists between those parts of the brain. And these are the things that are associated with symptoms of obsessive compulsive disorder. So what the TMS does is to inhibit activity in this part of the brain. Now, before we do, that's one thing about the application of TMS. Before you do it, it's not like you will just take the coil and just put it in any part of the brain. There's a bit of science involved. Now, you have to be able to locate, you have to know the part of the brain that is responsible for emotions and for behaviors. Like, I'll still talk about these things. Then you will now localize your stimulation to that part of the brain, and then it works. Also, TMS has also been recommended for the use of post-traumatic stress disorder. People who have gone through trauma and they are now having flashbacks, feels like they are reliving the experience again. TMS has also been tried for the use of post-traumatic stress disorder with good outcome. A study was done in 2019 that demonstrated effectiveness of TMS in post-traumatic stress disorder. And what it does is that it targets the prefrontal cortex. That's the part of the brain, the front part of the brain, which regulates how we process fear and worry. I'm sure you know basic science that the brain regulates behavior, emotions, our ability to think, our ability to organize, and all of that. Another use of TMS is for stroke, and this is for neurology. And that's why we said the use of TMS, it cuts across. We'll still see its role in pain management. There has been some evidences that have suggested that TMS can help with stroke rehabilitation. We know what happens when people suffer from stroke. And it said that there's a compromise in blood flow to that part of the brain, and then the brain cells begin to die. And when this happens, it can result in long-term loss of muscle movement. And that's why you see that people who have stroke will need physiotherapy. Now, research has shown that when people have stroke and they receive TMS treatment, it could promote motor recovery. And this will now lead me to talk about Parkinson's disease. Now, because we have practical experience with managing a client that had Parkinson's disease and major depressive disorder that came in. And even though the literatures suggest that TMS can improve motor symptoms or PAM, we didn't have first-hand experience. Someone dysfunction for Parkinson's. We know Parkinson's is a neurological disorder that often comes with tremor. So this patient had issues with balance, and there's something we call shuffling gait. It came with that kind of gait and had issues with balance, had tremors, and could not even stand by himself, in addition to depression. So what we did was, after family consented, we tried to get a neck collar to stabilize his neck on the machine, because the first session, we used the MagVenture TMS device. The first session was really not pleasant. Patient was not stable. But again, so practically, I had to hold the head of that patient for the first session. And this session of TMS takes about 36 minutes. And then we did the second session. By the time we were doing the fourth and the fifth session, patient already started to make improvement. He could walk himself into the consulting room, into the place for the TMS, and it was just amazing for us. Now, again, I'll still talk about the fact that people will respond differently to TMS. It's important to note that. I'll still talk about this. But for that particular patient, its response was really amazing, and it did so well. And patients started to talk. This patient could not feed before. He had selective mutism. In fact, he had to be fed using an NG tube. Before we knew what was happening, before the 30 prescribed sessions for TMS, patient was already well and did so well. And that's for Parkinson's disease, to improve motor symptoms of Parkinson's disease. And his mood also improved, even though he had to stay on medication. And we'll still talk about this. So that's TMS. And TMS also can be used for chronic pain. It has been said that it can potentially improve and conditions that present with chronic pain, especially because of its involvement in stimulating the motor cortex and also controlling neurotransmitters that are involved in pain. And then I think one more, TMS has also been used, been recommended for nicotine addiction. I think I'll leave this when I come to talk about the place of TMS in treating addiction. But again, like I explained, there is a relationship between substance use and mental illnesses. They can coexist independently. Someone can have an addiction problem and also have a mental illness, and they are not dependent on each other. We call it a co-occurring disorder condition, dual diagnosis. And then you can have so that kind of person, they have depression, they also have an addiction issue. So the use of TMS will be advantageous because it's going to help to manage the depression and any other mental illness that might be co-occurring with the depression. It will also help to manage the addiction. Or you have a situation where people have an addiction and the addiction now triggers a mental illness. And now the addiction now triggers depression, for example. The addiction now triggers anxiety, for example. So you now find that the use of TMS can also help to manage that. All right. So other conditions that the TMS has been said to be helpful are schizophrenia, including the positive and negative symptoms of schizophrenia. Now, I need to state that the treatment of schizophrenia using TMS is not approved by the FDA. So whatever people do is off-label. The same thing applies for bipolar, and the same thing applies for eating disorders. These are not yet FDA approved, but people have done some trials and it has been shown that this thing has a role to play. And that's why it is often referred to as a novel development in psychiatry, and that cuts across even neurology. I'll still come to talk about its role in addiction. So who is eligible to take the TMS? Who is eligible to take the TMS? Anybody that is above 18 can take the TMS. Anyone who is above 18 can take the TMS. And it is safe. The side effects are minimal. The books will tell you that the side effects are probably this pseudo feeling of sensation, tapping on the part of the head that you stimulate, or it can be headache that can be relieved by analgesic. And very rarely, people have talked about seizures and all of that. I'll come to talk about that eventually, but the TMS is safe. It's non-invasive. But there are people that cannot take the TMS. Anybody that has any non-removable metal in the head and cannot take TMS, and with the exception of dental braces or dental fillings, and they can't take the TMS. Or anybody that, if that metal is within 12 inches of the coil, because it can eat up, the TMS can eat up the coil and make it to malfunction. People who have cochlear implants, they can't take TMS. People who have cardiac pacemakers, implantable cardiovascular defibrillator, also they can't take TMS. People who have metallic implants in their ears and their eyes, or people who have bullet fragments close to their head, they can't take TMS. People who have facial tattoos with magnetic or metallic sensitive inks, they can't take TMS. And people with epilepsy or seizure disorder can't take TMS. We'll probably just talk about that eventually. So how do people respond to TMS? When people take TMS, now depression is what we are using as reference standard. People respond differently, like I said. People respond differently. Just the way people respond differently to medication, people will respond differently. And the success rate is about 60 to 70%. People they will experience improvement in their mood and all of that. How many TMS sessions do people need to feel better? It is also differs for different people. Sometimes I see my clients begin to make improvement at about the 10th session. Like what we do is this: before we start you on treatment, we have some evaluations that we'll do. And then when you are in treatment, after the 10th session, we'll repeat the evaluation. After the 20th session, we'll repeat the evaluation. At the end of the session, we'll also repeat the evaluation to help us keep track of the progress that people make in the course of treatment. And if you want to take treatment, it takes about 4 to 6 weeks. We recommend 30 sessions over a period of 4 to 6 weeks, averagely 5 sessions every week. And each session will last for about 36 minutes because of the treatment model that we are using. So, and what happens after people have taken treatment and they've gone into remission? By remission, we mean that symptoms are no more. Usually, people can have a recurrence after they've gone into remission. So some people will go into remission, they will not have symptoms, they will not feel depressed, they will not have symptoms of OCD, symptoms of anxiety for 6 months, for 9 months. Some will even run into years. If I had a client that where we did a session for her, I think that was in 2018 or 19. The last time she's off medication and she's not had another session of TMS, and then she's doing well. So we know that recurrence can happen. People can come back and have sessions, though there is no fixed timeline to that. Some people can go several years, some people can go 1 year, and then they might begin to have symptoms again, so they can come back. And the good thing is this: unlike medication, when you treat people with medication and then you do a drug holiday and people have recurrence on their symptoms, you might not be able to, the medication that worked may not work again, the dose that you will use might be different. But for TMS, that's not the case. The chances of remission still remain high. If somebody has had remission before using the TMS to treat their condition, the chances of remission still remain high. And what are some of the side effects that I was talking about? People could have headache, discomfort at the site of stimulation, and some people will report feeling lightheaded, and some people might have twitching of the facial muscles eventually, and some uncommon side effects are seizures. Very, very rare, less than 0.1%, and that. Okay. Now, there's something, some of us might be familiar with what we call the ECT. When I talk to people, when I talk to the TMS is a technological improvement. When people take ECT, ECT is the shock therapy. ECT is the electroconvulsive therapy. Because again, people always ask me this question. That's why I like to talk about it. They say, oh, so how would you compare the ECT, which is the electroconvulsive therapy, and the TMS, that's the transcranial magnetic stimulation? How do you compare? Okay, so let's look at it this way. We know that ECT is gold standard, but again, ECT comes with its own dynamics. In ECT, you are intentionally inducing a seizure. You are giving a shock, intentionally inducing a seizure. But for TMS, that's not the case. And for patients who receive ECT, they have to be sedated, and they need other medication, muscle relaxants for them. But you see, for TMS, that is not the case. Again, with regards to recovery, when people have had shock therapy, the ECT treatment, and recovery can occur slowly, and you have to monitor the patient for some minutes or even hours after a treatment. But that is not the case with TMS. People can come from their office during their break time and have TMS, finish it, they drive back and go back to continue their work. That's also another thing that can make us consider the TMS. There's also, for the shock therapy, there's also the short-term confusion and memory loss that are often been associated with the electroconvulsive therapy. But that's not the case with the TMS. There's been no feedback. I mean, literatures have not captured post-sessional confusion that often come with the ECT. And so with TMS, you need, because of side effects associated with ECT, I mean, you might need significant amount of caregiver support, but that's not the case with TMS. That's not the case. So that's why it's something we want to consider. And let me quickly talk about TMS and seizure. When people have had seizure, when people have a history of seizure, the TMS is contraindicated. When people have epilepsy, TMS is contraindicated. And TMS does not cause seizure as side effect. It is rare. That's what I mean to say. It is rare. Because this is another fear that people have, that, oh, the shock therapy might cause this. I mean, it is rare, like I mentioned. So what happens if TMS does not work? We need to talk about this because the efficacy is not 100%. What happens when it doesn't work? So it is better to combine TMS with medication. Sometimes people come and say, doctor, you know what? I just want to stop medication. Fine. If the medications are not tolerable, that's okay. But if medication can go vis-a-vis TMS, it is often recommended that people should stay on their medication while they have their sessions of the transcranial magnetic stimulation. And if for some people the TMS may not work at the first time, after your first treatment session with TMS, it might not work. But again, we recommend people to have a second course of treatment. And usually that is recommended in addition to some other form of treatment. If it is possible to combine it with medication, and if it is possible to combine it with psychotherapy, we cannot leave out the role of psychotherapy in the management of mental health conditions and also substance addiction. So now, before I end, I'm going to talk about TMS and addiction. Very important to talk about this. TMS and addiction. So, what's the role of TMS in substance addiction? We know how complex it is to treat addiction. I mean, very complex. The definition of addiction in itself is that it is a chronic relapsing brain disorder. It runs a chronic course. I mean, sometimes you will see people who have been in rehab the second time, the third time, the fourth time. So addiction in itself is complex. And some people say, okay, is there no medication we can use? Yes, we know that lately there are some medications have been used off-label to reduce cravings. That's something. It's important to state that the use of addiction is experimental. State that the use of TMS for addiction is still experimental at this time. It's still experimental, but it appears to have a very promising future. Studies have been done, and studies have shown that TMS has a role to play for addiction. And usually, what do? There's a part of the brain we call the dorsolateral prefrontal cortex. Now, that's the part of the brain that is responsible for some functions, and that's what the TMS does. It stimulates that part and then helps to reduce craving and puts people in control of their addiction, specifically with regards to nicotine, cigarettes. And we know what nicotine does. Nicotine releases dopamine, and dopamine, like we know, is the feel-good hormone. And then you know the relationship between that and the reward system of the brain, especially the prefrontal cortex, and which now makes people to continue to crave. Now, the same pattern, the mesolimbic dopaminergic pathway for addiction, for cocaine addiction, for example, is the same pathway for nicotine addiction. That is why the TMS really helps. So what the TMS does is that it stimulates that specific part of the brain and helps to reduce craving. It helps to reduce craving. It does this in many ways. I'm not going to bore you with that. For example, it's been said to promote the release of dopamine. So the person will not have a reduction in the need for cotinine or any of the other substance that they use. It's been said that TMS has a role in cocaine addiction. Studies have reported significant reductions in cravings for cocaine and also in the quantity consumed by people. I've had patients that we've used TMS for addiction, and many of them reported reduction in craving. And like we've talked about, there is no serious adverse effect. So when you now combine, it is said that when you now combine TMS with psychotherapy, it has a lot of impact, and it is very promising for cocaine addiction. How about alcohol addiction? TMS has also been seen as a potential treatment option for addiction. It also helps for alcohol addiction. It also helps to manage craving. I've talked about cigarettes and that. So even though the place of TMS in addiction is still experimental, and I'm emphasizing on that, and studies have really shown that when it is combined with other forms of treatment, like people going in for rehab and having therapy, psychotherapy, that the result is usually amazing. So at this point, I would want to pause. I mean, that's just the overview of the TMS in management of mental illnesses and addiction. And the good news is this: we have TMS in Nigeria. Some years ago, when we brought TMS to Nigeria, there were only 2 machines in Nigeria, but now some teaching hospitals have started to procure. I am aware that Ahmadu Bello University Teaching Hospital has procured the machine. I think I'm also aware that Aminu Kano Teaching Hospital has procured the machine. So if you are looking for a place to refer somebody to, or you need more inquiries, you could come in and see what the machine looks like. And we are hopeful that people will do well with this treatment. Thank you very much, Mr. Femi. Over to you. Thanks for listening.
Thank you very much, dear guest, Dr. Bukola Williams. I think he's done more than enough to take us through the efficacy of transcranial magnetic stimulation in drug addiction and mental health treatment. And I'm sure for quite a number of us on the space today, we're just getting to know this. That's getting to know what TMS is all about. And it's interesting to also know that it's a new technology that is just coming up. Only 2 of that in Nigeria at the moment, one in Abuja and one in Lagos. That's quoting Dr. Bukola Williams, who is a mental health physician and TMS specialist. Thank you very much once again, Dr. Williams. I'm sure you probably have quite a lot to attend to today just on the space, because we have quite a lot of questions for you coming in, tripping in our DM, as well as those on the space. But before we go into that, let me quickly acknowledge some of our prominent guests already on the space. Dr. Abdullah. Dr. Abdullah is is a consultant psychiatrist at the Ahmadu Bello University Teaching Hospital, Zaria. Thank you, Dr. Abdullah. We also have another great young man that I just noticed him, and that's Oshinobi Oluwafemi. I saw something he's doing interesting there. I will come to him. Oshinobi Oluwafemi, thank you for joining, for being part of the conversation today. We've seen Mohammed Bafo, and I've also seen our own very regular, that's John Ogunjimi. Thank you, John, for being part of our conversation today. I've seen Abiola JP, and again, another constant member of the platform, that's Perpetua Nnamdi Mane. Thank you, Perpetua, for making it coming around today. I have also seen Kari Obi, Ibrahim Mayo, Demo, and a few of some of our young, dynamic new officers. Dr. Dimeji, that's at Avata. I have seen Neta. I have seen Ibitoye. And I've also seen another regular person, that's City Boy at City of Mogbola. Thank you, guys, for being part of the conversation today. I've also seen a Youth Action Network on Substance Abuse. Thank you for being part of this conversation today. We have Regina Ejegerin. Regina, thank you for coming around. Alessandra has actually been trying to come on the speaker's corner. Unfortunately, I guess his network has been failing him because I have approved his request a number of times, but his network would not allow him to stay. I've also seen our own very Dr. Loretta. Loretta is joining us from Chicago, Illinois. I think Loretta will want to take Dr. Williams on because she's already well seated on the speaker's corner. Thank you, Loretta, for being part of the conversation today. I've also seen another member from the US, that's Tinuka. Tinuka is joining us from Maryland in US. Thank you, Tinuka, for joining us. I've also seen Jafar Umar Abba. Jafar, thank you for joining, be part of the conversation today. I've seen our own patriotic Ken Patriot. Thank you, Ken Patriot, for being part of the conversation today. We'll continue to recognize some of our people, but then now, okay, where do we start from? Who do I start from? Okay, I think let me give the first space to, okay, Dr. Abdullah, please permit me. Let me quickly, because I know Loretta, it's our timing is different. Let me just quickly take Loretta first, and then I'll come to Dr. Abdullah. Loretta, let's hear from you.
Thank you, Dr. Babafemi, and thank you, Dr. Bukola. That was a well-detailed discussion on TMS. Wonderful. I've heard about TMS just very recently, but as you began talking about it, I had to follow through by Googling and actually seeing exactly what it is. I'm a community psychologist, community clinical psychologist, and I work with people in recovery in the United States, and I'm also a harm reduction advocate. Before I ask my questions and clarifications from Dr. Bukola, I just wanted to mention something to Dr. Babafemi that you will need to check something on this platform. I realized that people come to this platform, take the points we make as we talk, they put it in different kind of blogs and media spaces, put it and it's published, and the way they tag what we say, it's wrong. I'd had the opportunity to Google my name a couple of weeks ago. I wanted to bring this to your attention, but I forgot, but I just remembered. And a Business Day newspaper tagged me saying I said something about cultism and drug use, and I know it must be from this platform because this is the only platform I speak about Nigerian drugs. And another blog talked about something, and I do not know, but I think if you're a media person on this platform, two things very importantly: if you need to use any content we talk about on this platform, I would strongly recommend that you link Mr. Babafemi up and get an approval for him. Otherwise, some of us might have to begin to sue those organizations, and I'm very serious about it, because you put our name, you put where we stay, you put what we do, and you say all kinds of things. The things might be correct, but the way you put it and write it is totally wrong. So thank you. Now back to Dr. Bukola. Thank you so much. I have just two questions. As much as we know that there are genetic disposition and environmental dispositions that make people use substance, and I like the fact that you mentioned that TMS is a recent thing that is being used for substance use disorder people. It's basically for depression and OCD, like I also read, like you mentioned. My concern is there a package that involves the TMS for substance use amongst your clients you talked about? Or is it a one-off thing? Because I do not see how effective the TMS will be for people with substance use disorder if it's a standalone. And if you've been using this for your clients with substance use disorder, what is your complete package? Because I'm mentioning this because I know there are people on this space that would like to access the services. But I want you to come out clear and say that TMS is not just, the pathway for addiction and recovery, but it's a package. And from what I read, I also discovered that TMS is mostly used when we have people in substance use disorder cohort that are relapsing, and just to help them to reduce the craving. So that's my first question. And the second question is, how do we deal with people that have the baseline for their substance use that has become a disorder? How do we help those with the environmental influence? Because for the genetic ones, we know it could go a long way. Environmental, it can help reduce the craving. But the question is, once they go back, what is the complete package? That once they go back to the community, that kinds of influences them to use, what's the therapeutic or psychological packages you have in total to help them deal with these issues? It's a mouthful, but I'm sure you picked a couple of things I said. I'm really concerned because Nigerians want to jump into this and oh, it works, but they also need to know what the complete package is, that it's just by the side and it's also being tested as well. Thank you.
Thank you, Loretta. Over to you, Dr. Williams, please.
Thank you so much, Loretta, and thanks for all what you're doing in the space of harm reduction. And I think we need to to hear more about harm reduction in this part of the world. I mean,
Dr. Babafemi is going to kill me. He does not want me to talk about it. He's going to kill me.
Yeah, no, but we need to hear about it. I mean, I understand how it is
Loretta,
in our
don't mind her, Dr. Williams.
In our culture. I know how it is in our culture. I am for harm reduction, and I mean, you have a fan in me from this moment. I'm for harm reduction, and we must brace up and embrace it as an alternative to treatment. All right, just to respond to your questions, thanks very much again for your question. Let me go for the second question first, where you talked about what's the complete package for people who come into treatment and then go back into the same community where the triggers, the external triggers exist. That's generic, and we know that one of the triggers for people relapsing is the environment. What we do, what my service does is this. We have what we call our community psychiatry services, where after people come into treatment and they've gone through rehabilitation, depending on the duration they stay in treatment for. We have an outpatient plan that we do that incorporates the recovery capital of the client. You know what I mean by recovery capital? There's social resource, family support, community support, and so this is what we do. We have an outpatient plan that allows them coming for regular therapy sessions with the psychologist, and then if they are on medication, they also need to see the psychiatrist. And then we also have a system that they consent to that allows a team led by the social worker to visit them. We have social worker on the team, so a team led by the social worker, the psychologist, and any other member that will join the team to visit them at home. That also helps to explore what their external environment looks like. So that's the recovering. Like we all know, that recovering from addiction is not predictable, and it's not a destination, it's a journey, and that comes with its hurdles, especially the external environment. So this is the structure. We have a structure that the client consents to, and also the people they identify as their support system, family or their sponsor, also are aware of this. And then we've tried to follow this through. They come to the facility, we go out to support them. I hope that answers your second question. With regards to the first question, so TMS will not be first line for addiction. TMS will not be first line for addiction. As a matter of fact, TMS is not meant to be first line for depression. We understand the commercial part that comes with I know in other parts of the world, people try to, I mean, like in your place over there in the States, I mean, there's a lot of commercials coming up where centers are trying to promote their TMS services and then makes it look like, oh, if you've just been diagnosed for depression, looking for TMS. But again, TMS is not meant to be first line. But again, patient preference, patient option will be respected. If a patient gets diagnosed for depression, for example, and they say, you know what, I don't want to go out to take antidepressant, I just want to explore therapy, would we now say we'll not offer that service to the patient? So patient factor is also, it's also there. And also for my clients that I've worked with, using TMS, clients with substance use disorders. So in the course of treatment, many of them will tell you that their cravings have improved, but we don't do TMS one-off. Even if they've had a first session, we try. For us in the country, insurance doesn't cover it. I'm aware that TMS services in some centers in the States could be as high as $12,000. I mean, as low as $6,000. But here in Nigeria, I mean, we've tried to make it low, but with how low it is, I mean, it's still difficult for people to afford. So what we find is that sometimes when people come, they've had their first session of TMS and they are now in outpatient. It is recommended that there are periodic sessions of TMS. Vis-a-vis psychotherapy, it is recommended, but we've not been able to achieve that significantly because of the cost that comes with it and some other dynamics. But again, the plan is this: when people have had a session, a treatment course of TMS for addiction, it is important to integrate it into their follow-up plan vis-a-vis psychotherapy. I hope that I responded well to your question, Loretta.
Absolutely, you did. I just hear that. Just to clear, do you use MAT and CBT during your treatment?
Yes, we do.
Absolutely. Thank you. Well done.
All right. Thank you very much, there, Dr. Williams and Dr. Loretta. Thank you for your interventions. Okay, let's we'll go to a very senior member of the platform, Dr. Abdullah. After that, we'll come to Oshinu Bioluwafemi. Dr. Abdullah, it's nice to hear from you again. Please go ahead.
Thank you very much, Mr. Femi Babafemi. Good afternoon to you and to all the listeners. Good afternoon to Dr. Bukola for an explicit presentation. Of course, he did make correction to that assertion he made. I wanted to protest when he said we had only 2 TMS machines in the country. I am proud to tell you that our TMS services have been operational since late last year in the ABU Teaching Hospital Zaria. And to the glory of God, I am heading the unit. And you rightly say, we have a lot of trials that are ongoing. Usually, as a scientific community, we don't discuss about these things until they are actually published. But of course, from the results we are seeing, TMS has a lot of promise. Like what is more concerning for this platform is about its place in the management of addiction. From the results we are getting from the studies we are doing here, we have actually seen that, in fact, within a month, we've been able to see significant reduction in craving, significant reduction in the withdrawal symptoms, improvement in mood, and the regaining of the cognitive control, the regaining of the control of the person, that is leading to increase in their motivation and ability to make certain vital decisions. We have seen that just within a month on the start of the trial. But of course, until we publish these findings, we will not be able to talk about them on a public space like this. I must say that yes, TMS, as promising as it is, I don't want people to get it all wrong, that it is El Dorado, it solves all the problems. No. It also has a downside, and the cost. If you look at majority of our people, truly as it stands, are unable to afford it. I think currently, even though I know many public hospitals who have procured the facility, we are the only public institution in Nigeria that currently offer CMS services in Nigeria. Okay, and even at that, you can imagine how cheap the public health services are. As cheap as it is, we still charge up to 50,000 naira for the services, and majority of people cannot afford it. If you compare the cost of
Dr. Abdullah, the 50,000 is that per session or for the treatment, for the whole treatment?
For the whole treatment.
Okay.
For the whole
That's cheap. Wow, that's great.
Yes, very cheap. But of course, if you look at the people that come to us, in fact, sometimes maybe out of 100 patients that will come, maybe only about 5 or 10 will be able to afford it.
Wow, wow.
Yes. You know, so it has a downside when you talk about the cost. You know, so it is like that. And these other things you mentioned, even schizophrenia, we have started trials on it, and in fact, the results are wonderful. We've had cases of resistant schizophrenia where we decided to compare the efficacy of TMS with ECT, and in fact, very, very interestingly, the result, in fact, we didn't find ECT to be superior to TMS in the treatment of you know, the results were neck on neck. And we have also used it with great success in the treatment of sleep disorders. So far, for the patient we have managed on sleep disorders on TMS, so far the result has been 100%. All right, but of course we want to get enough data to be able to put it out publication so that it will be evidence based. So TMS is actually very interesting, but of course we need to look at the socio-economic environment we are in. Now, coming to drug addiction, I don't see TMS standing alone as a treatment. There must always be that psychological component of it, because before you rehabilitate somebody, the person has to be motivated enough. So you will need motivational interviewing, you will need cognitive behavioral therapy, you will need cognitive enhancement therapy, you know, all those. So TMS at best will always be a very important adjunct in the management of addiction. That is what I think. From everything we have seen here, from our evidence, right now I'm sitting in the TMS room, and we have a lot ongoing. And I think by the time we begin to churn out the results, I'm sure people will be very excited about the whole thing. So thank you very much for this presentation. Thank you.
Thank you very much there, Dr. Abdullah. Dr. Abdullah is speaking with us on the efficacy of TMS from his TMS room right beside the TMS machine. Thank you very much.
Same here. I'm right beside Dr. Abdullah. I'm right beside the machine here too.
Okay. So you guys, okay. Since it's TMS day, so
Dr. Babafemi, sorry, let me just say something with all due respect. Please, I like that Dr. Abdullah and Dr. Bukola said, and they are reiterating it, and people have to understand that TMS is not a first line, it's an adjunct. It's an adjunct, it's not
an adjunct.
Family, friends who are going through substance use disorder, don't just say I'm taking them for TMS treatment. No, it is an adjunct. It is not first line or second line. Please,
thank you. Thank you very much there, Loretta. We appreciate your intervention. Dr. Williams, I'm not sure you want to say anything to that. Please,
I just want to say kudos to Dr. Abdullah. I knew when your center procured the machine, and I know that they reached out to me. I've been on the lookout. I mean, hoping that, in fact, as a center, we've tried to see how we could get the machine into some government institutions and to see if prices could be subsidized. You can imagine ours is not as cheap as yours. So expectedly, we are not going to get as much traffic as you are getting. No, we will not. We will not.
Dr. William, don't mention your price here because
No, we will not. We will not. We will not.
at least
We
Dr.
will not.
Abdullahi has
That
made has calmed some nerves with even 50,000 for the whole session. Nothing.
yeah. So hopefully we'll probably send some patients over to you. And again, I like the fact that your system is a teaching system. You've got the traffic of patients, and then you've got capacity for research. We've seen some of these things, like you rightly said, that when you don't have enough figures. You can't just speak conclusively in the public space. In fact, the result we had with TMS in improving motor symptoms of Parkinson's, we had to publish it, and because it was novel. That was about the first time, and we were doing that. But well done to your team, Dr. Abdullahi. I'll try to get in touch. I think I'll do that through Mr. Femi to see if we can collaborate on a few things.
Very well, thank you very much, there, Dr. Williams. That's one of the things our platform is all about: bringing experts and knowledge together to save humanity. Thank you very much once again. I think we'll take our next intervention from Oshinobi Oluwafemi, and thereafter I'll come to Regina Ejere. Okay, Oluwafemi, Oshinobi, please unmute yourself.
Okay. Good evening, Mr. Bakami. Can you hear me?
You're loud and clear. Please go ahead.
Okay. Good evening. Thank you very much for the opportunity given to me. And about this transcranial magnetic stimulation, I really appreciate the fact. Though this is my first time of hearing about that. I'm a sport enthusiast. I'm an advocate for drug abuse too, and also trafficking as well. So I think I want to ask a question and a contribution. So I'll make it very quickly. My question is, how can we incorporate this, in the midst of youth? Because I think I carried some assignment last week in which I shared it on the platform about raising against drug abuse, in which I use sport as an avenue to fight against drug addiction and substance abuse, in Nigeria as a whole. But the motive behind this challenge is just to inspire youth to break free from drug abuse, and by promoting an healthy and active lifestyle through this initiative. That is the reason why I am promoting this sport as a fitness, to promote to make sure that youth enjoy a healthy and a free lifestyle. And with the help of government and with the help of NDLEA, and I believe they can even help us to even encourage this, and with this use of this transcranial magnetic stimulation too as well. So Mr. Babafemi, I don't think my question is now that how can we incorporate this in youth? Because it's getting worse. There are some sensitive things I can't even share on the platform, in which I went to some communities and villages. What you're even saying is more than that over there. It's more than that over there. So, how can we incorporate this? And I believe I can even share more of it with you, maybe after the program, and see how we can work together, to achieve this greater mission.
How can we incorporate what? Is your question directed at Dr. Williams?
Yes, directed to Dr. Williams. Is how can we incorporate this transcranial TMS, into youth? Because I believe if they can be able, if they're not free from this, I'm not sure this TMS can work. Can work in them. If they're not free from this, all these social vices of drugs, I don't believe it can really have a full effect in them. And that's why I said that there are some sensitive. Right. Yeah. Go ahead.
All right. Thank you very much. Dr. Williams. I'm sure you can make something out of what you said. You can now mute yourself.
Thank you very much, Dr. Wafemi.
Thank you so much. Okay, thanks for all is said. I think it is what it is. It is what we've said. I think we will just have to think of how to make this TMS accessible to those who need it and to those for whom it is indicated. Like we've said, it is not indicated for everybody. It is not first line. It is adjunct in treatment. So I think it's a conversation that will be ongoing. And I'm so glad for what ABU Teaching Hospital has started to do, make it available. in bold for those who very much.
All right, thank you very much, there, Dr. Williams, and thank you, Femi Oshinubi, for your contribution. Also, please feel free. That's talking with Dr. Oshinubi now. Please feel free at the end of the program, or if you have anything you need to clarify or anything you need to discuss with me or take up with me, please feel free to come to my DM. I think I already noticed you. I think yesterday or so, somewhere when I saw some of your posts. Please feel free. I'll definitely respond to you. Okay. Let's take the next contribution from. Is Regina still around? Okay, I think she's dropped from. Okay, let's take the next one from Dr. Dimeji. Dr. Dimeji, that's Avatar. Please go ahead and mute yourself.
Good afternoon, sir. Thank you very much for this opportunity, Mr. Obafemi, and also Dr. Bukola. I'm so much grateful. Your lecture was very educative. I was making notes, and I've actually read about TMS, but I've not seen it being used before, and I think it's a very good idea. Some of the questions I wanted to ask have been asked based on affordability. When the doctor from ABU says about 50,000 per section, but my concern now is how do you said you could have about 30 sections for treatment. How do you do follow-up? What of patients or clients that you might lose some of them on the way? How do you ensure that some of these they complete this session? How have you been able to take care of problem of lost to follow up? Because sometimes we're in Nigeria and some people start before you know they might not continue, maybe because of little improvement or because of fun too. So then also have you thought of discussing with maybe the NHIS to make it an all-inclusive program in their NHIA, sorry, so that it could be affordable too? Because if NHIA covers it, you could see that most of the clients you have that might need this TN in Nigeria now are actually the low-end people. And if NHIA covers it, it might go a long way to also have good coverage also. Then also, I want to ask on training. Do you, how easy is it to operate? Do you think doctors can be trained to operate this, and then can it be easily used in little clinics or even in the office?
All right, thank you there, Dr. Dimeji. I think he's off line at the moment. Okay, Dr. Williams, I think you are free to speak to his points. Thank you.
Okay, thank you very much. I'm glad he will be able to go back to see this. With regards to the NHIS, let me start with that. I mean, it will be very good. I'm aware that in other parts of the world, insurance covers it to a large extent. Insurance covers it, and I think it would be a good one to have. I mean, we would see. We work with a couple of HMOs, and then we'll see how we can get them. I mean, if they cover psychiatric facilities, services, they can also probably integrate this. That's a very good one. I'll probably take it up with the team that works on that. With regards to operation, yes, people can be trained. In fact, I don't envy Dr. Abdullahi alone, because I know that it's just that for ITMS, once the patient is on the machine, we're still within the confines of that place. You can attend to some other things and probably do some other work and keep an eye on the patient. But I mean, if you have the kind of traffic they will have in a place like ABU, I mean, if everybody were to receive ITMS, it would be very enormous. So I think there's a place to train people to be able to use it. And so for us, we had to get certified and did all of those things. I mean, but then we understand that somebody can go learn something and come back and impact the knowledge to other people. I mean, that's knowledge dissemination. So there's a place to train people, and they are, and others will probably fit from from that training. And with regards to follow up, we understand the dynamics around people getting lost to follow up. I mean, a lot, not even just in psychiatry alone, but for TMS. And because for follow up, whether for mental illness, for example, I mean, it's a challenge. You have to, in fact, we have a system because we have our community approach. We have our social worker who follows up on our patients and ensure that they can, as much as possible, adhere to their schedule, their visits to the team. And you still lose some people to follow up. Some people, however you follow them up, they will not come. However, the psychoeducation you'll do, some people they will still not adhere to medication use. You still use that. But for TMS specifically, I think only a few cases. I mean, not much. It can't be more than 2, 3 that they didn't finish because they improved on treatment. Interestingly, one of them was a doctor. You know, like they will always say, doctors can be bad patients, quote and unquote. Please don't quote me anywhere. I mean, this person had done well on treatment and didn't finish the session because they said they had done well. But again, knowing that you paid such an amount of money for treatment, we get close to 100%, I mean, completion. But maybe a few, maybe 2 or 3 people that didn't finish that. I hope I've been able to respond to your question. I don't know whether Dr. Abdullah would want to probably say more to that on his experience, since he's also started to use. At the time, I was the only person in the country who was doing our TMS service, and I'm so glad that, I mean, we have other people coming into it. So maybe Dr. Abdullah might want to share his experience.
Yeah, thank you very much. In the area of training, between last year and right now, I think I have trained 15 of our resident doctors here, and so they are doing well. Whether I'm around or not, they are able to give the TMS. In respect of loss to follow up, mostly the loss to follow up is as a result of the cost for most people. Usually the person feel like, okay, I have done well. I don't want, usually they finish when they pay for the session, they finish the session. But if there is need to continue, mostly, because of the cost, people will usually are not willing or are unable to continue because of the cost. Perhaps, where I practice, majority of the people are belong to the lower socioeconomic strata. So 50,000 is a lot. It's a lot of money. And usually you can see patients defaulting on treatment, even for treatment that costs 10,000 naira per month. They can default on it, let alone when you have about 50,000 naira. But of course, we do community psychiatry, but of course, it is not very effective per se. So it's difficult because I think the entire department we have only about 4 social workers, so it is difficult to go after our patients. Look at the number of patients and decide in
patients.
Yes, in a day, apart from the old patients, we can see up to 200 new patients. So it is it's a whole lot of work. It is practically impossible to follow up, even if you want to do so. So the only thing you do the psycho education at the point you are seeing them, educate them about the need for compliance and adherence. And those that that take that home, they are able to come back for follow up. But a lot of people actually do not come back for follow up. Yes.
Wow.
Thank you very much.
And for us, what we do is that payment is made in bulk. Only on a few occasions would we say, okay, do this percentage and do this. So I mean, once you paid, you are kind of committed to finishing it.
All right. Thank you very
thanks,
much,
Mr.
Dr. Abdullah and Dr. Williams, for sharing some of their experiences in their practice with us. We appreciate all of that. Okay, we'll now go to our DM. I believe I've taken care of those requesting for the mic for now here. Let's quickly go to our DM. Dr. Williams, you may have to note down some of these questions. Let me just ask this first set, 3 on a roll. I'm sure some of them you would have answered in your earlier presentations, but just how, okay, Tina is asking, how affordable is this particular procedure and what can you say of its success rate? That is one. Two, are there any side effects to this? I'm sure you have discussed, spoken about that before. Are there any side effects to this process? And three, the last one from Tina is, what are the chances that it wouldn't result in mutation, especially in people with certain brain disorders, such as bipolar disorder and epilepsy? You may want to take the three, then before we go to the next set. Go ahead, Dr. Williams.
Okay, thank you. With regards to side effects, we've talked about the side effects. We've talked about side effects, very rare. I mean, the most of we see is this twitching sensation on the head, this pseudo tap after the session, because you know how it is. I wish I could put on the machine so that you will hear the sound of how it goes. I mean, sometimes after the session, people tell you, doctor, I just feel this thing tapping on my head. Then usually headache. And once just one dose of analgesic takes care of that, it doesn't recur. So, I mean, it's well tolerated. That's with regards to side effects. With regards to mutation, there hasn't been any reports. It's used in bipolar. I'm happy Dr. Abdullah's team has been using it in schizophrenia. Because, I mean, in places where it's been used, it's been said to improve especially negative symptoms of schizophrenia, and as well as also help to manage some positive symptoms. So mutation is not something that has been reported, I mean, at least not within the literatures that I've read and that I follow with regards to TMS. And with regards to cost, it's relatively cheap. And that's all I can say. I mean, compared to, I know Dr. Loretta, I don't know if she's aware of some of the costs, but I know from what I know that you could get it for as high as $12,000 in America, as well as $6,000, and convert that to Nigeria. That's a lot of money. But
Okay, it's like we lost you there, Doctor. Your network is fluctuating. Dr. Williams?
Yeah, I wanted to also mention to Dr. Williams, Dr. Bukola, that a session for TMS, as Chicago is concerned, is between $300 to $500 for one session. And if you say that it's between $300 and $500 for one session. It's as in one time.
Or 500,000 naira.
It's between $300 and $500.
Yes, I'm converting it to local. I'm converting it to naira.
So if you have to go through 10 sessions, you're looking at $500 times 10.
Wow.
I know where that is.
So that's a lot of traffic for Ahmadu Bello University Teaching Hospital that for the whole package.
But they cannot charge the way it's charged here. And because some part of it is taken by insurance as well. So Dr. Abdullahi, please, if we don't want this thing to just be an elite treatment and opportunity, let's see how we can make it affordable to those in the hinterland, in the rural areas, which, I mean, I really doubt.
That's what Dr. Abdullahi was saying, that even the 50,000 for the whole, not a single session, not one session, 50,000 for the full package. Is 50,000 for the, yeah, that's what he's saying.
For the 10th, is Dr. Abdullahi still on the line? Yes, is he saying that 10 session is 50,000? That's interesting.
Dr. Abdullahi, please, can you clarify this, confirm this?
Oh yes, we do 50,000 for the entire treatment process.
Because I know I heard you right.
How long is the treatment, sir? How long is it?
In fact, patients are still complaining. They say, this is too much.
How long is the treatment? For how many times?
The other sibling of TMS, which is ECT, we do it for 15,000. So for them, from 15,000, you are doing something 50,000. That's too much.
And
Dr.
another is
Abdullah,
asking how long does it take?
Doctor, how many
The treatment.
sessions is the 50,000?
No,
How many
usually
sessions?
it is individualized. Mostly we do average of 6 weeks, twice a week for 6 weeks.
Twice a week for 6 weeks. Yeah, okay.
But of course, you will have some people who will require less, some who will require a little more. But the average is 6 weeks, twice a week, 35 minutes per session, twice a week for 6 weeks. That's what we do.
All right, thank you very much there. Please still hang around, Dr. Abdullah. It's obvious Dr. Williams is having a struggle with his network. Pending when he comes back, there is this very important question I would like Dr. Abdullah to attend to, pending when Dr. Williams comes back. Dr. Abdullah, please listen to this. There is this is a question sent to me now. This is a question sent in now. It's saying there is a survey report I read 3 months ago on TMS
I'm back now, Mr.
having
Femi.
adverse
In case
effects
there's any
on
question for me,
patients whose
can you
bodies.
hear me?
Okay, okay, you are back, Dr. Williams. Okay, please listen to this, Dr. Williams. I'm sure you and Dr. Abdullah would like to speak to this. Please listen to this. I'm reading a question sent to me out now. There is a survey report I read some 3 months ago on TMS having adverse effects on patients whose bodies have undergone some level of BBL. I'm sure we all know what the BBL, that's the new back that ladies are doing, or some level of body enhancements. Can Dr. Bukola confirm it? And is it possible to warn people to avoid abusing illicit substances when they know they have undergone such surgeries? Okay, please let's have the two experts on this to speak to this issue, please. Dr. Williams, please go ahead. Then we'll have Dr. Abdullah wrap it up.
Okay. I've not come across any such though. I don't know if Dr. Abdullah has come across any such. I have not come across any such in practice. And I'll be very interested in seeing that study. I'll be very interested in reading through. I'll be grateful if you can share with us, please.
All right. Thank you very much. Like Dr. Bukola mentioned when he was making his presentation, the only absolute contraindication to this procedure is having a metallic object that is a magnetic material, which we always metallic object that you cannot remove from the person's body. Usually here, if you look at our protocol, even there are some certain tattoos that if somebody have, we will not put you through the TMS, as long as there is a heavy metallic component of the ink that was used to tattoo whatever it is on your body. But once there are no heavy metals, then there is no any problem as regards that. We have people that have like a cardiac implant, cochlear implant. All these are metallic objects that you don't want to put them through the magnetic procedure because there's going to be a reaction. So that's the reason. So there are people that have tattoos, and if you look at the component of that ink, there are heavy metals inside. That is also a indication to TM. Yes, that's as much as I know.
In fact, Dr. Abdullah, I had a patient that she had a Link's ring. She had gastroesophageal reflux disease, and then she had a surgery overseas, and they put a ring somewhere between the duodenum, the stomach, and the first part of the duodenum. We weren't very sure what it was, but we couldn't go ahead. In fact, we had to she had to reach out to our surgeons, and we had to explain what we were going to do, and they had to tell us to go ahead. So besides this contraindication, there is none that I am aware of.
That was the right thing to do, actually. That was the right thing to do. Thank you.
Yeah.
Okay, thank you very much to both of you, Dr. Abdullah and Dr. Williams. Let me quickly read this other one in my DM. Where am I now? Okay. It is very easy to notice the similarity between TMS and ECT since both involve placing an element over the head that sends signals to the brain. Since TMS and ECT are similar, what about side effects like seizures and cognitive impairment? I'm sure you have spoken about this, Dr. Williams.
Yes, I mentioned this extensively. I talked about this, yeah.
Okay, then let me take this one also. What are the other human behavioral patterns that are consistent with substance use and addictions? Because I'm wondering if TMS targets brain functions that are consistent with cravings or appetites, how will this affect the normal function of the patient after they receive TMS? Or is there a way to manipulate the TMS such that only drug cravings are inhibited? Wow. Yeah, Dr. Williams?
Okay. Okay, that sounded quite very intellectual, a question. Okay, so let's see it this way. We know that's why we say to people that, to treat addiction, you can't go and remove the pleasure center. No, if you go and remove, you can't go and do surgery to treat addiction. But again, we know the way it works is this: when people use drugs, they still eat now. They drink. I mean, they enjoy pleasure regularly. What addiction does, especially to the dorsolateral prefrontal cortex, is that it makes it hyperactive, and it also affects the executive function. So what TMS does is just to restore it to normal. So it has no impact on whether your food and your other pleasure sensations. It just restores it back to normal. Because even when these things were affected, when your dorsolateral prefrontal cortex becomes hyperactive, becomes inhibited, you've retained every other part of your life. So what TMS does not really impact on those other things that you mentioned. I hope I have been able to respond to this question. Dr. Abdullah might want to impute to it.
Okay, thank you, Dr. Williams. Dr. Abdullah, you want to speak to that?
Thank you very much, Dr. Bukola. Let me see. I don't know if I can add something. The brain has brain regions. The cortex is the most developed part of the brain. Now, there's this part of the cortex, that is called dorsolateral prefrontal cortex. It is basically the area of the brain that is responsible for helping individuals to take decisions, to make choices, Now, there is another part of the brain that is not very developed. We call it the amygdala. It is part of the limbic system. Now, this amygdala, it works on what? Just instinct. It works on emotions. All right? So it is this dorsolateral prefrontal cortex that has inhibitory effect on this amygdala. All right? So for people who use drugs, they suppress the function of the prefrontal cortex. Thereby, the brakes it is supposed to apply on the amygdala is not there. The amygdala has a free rein. And so the person feel like, I want to take drugs. There is no, that part of the brain that's supposed to tell him, no, it's not safe for you to take drug. I want to do this. It's not safe. Take it easy. Don't do this. Don't do that. That part of the brain is no longer functioning very well. So the person is just doing things according to his emotions, based on what the amygdala tells him. So what the TMS does is to reactivate the function of the dorsolateral prefrontal cortex, so that it regains back its control over the amygdala, so that exert control for you like drugs. But if the dorsolateral prefrontal cortex is not working very well, you will not be able to resist that desire. You will just play along, depending on what the amygdala tells you. So basically, what the prefrontal cortex TMS does is to help the dorsolateral prefrontal cortex to regain back that executive control over those primitive structures, so that you are able to resist those primitive impulses. It's not just drugs, including other things. All right. So
Thank you very
that is
much.
what happens.
All right. Thank you very much, there, Dr. Abdullah. We have just barely 10 minutes to wrap up on this conversation today. It's really been very, very informative and educative. I'll tell you, I know the feedbacks I'm getting. Okay, I'll still have the two of you gentlemen to respond to this. There is one more from the same source, from the same person. That's the last question from either him or her. I don't know, but then, okay. Now the question is: at what stage of addiction should TMS be considered as a treatment option? And are there particular drugs of addiction that TMS is more effective in treating than others? I think that's another brilliant question. Over to you, Dr. Williams. Maybe Dr.
Okay.
Abdullah would also respond later.
Thank you very much. Good question. Again, like we said, we know that it's usually prescribed that first-line treatment for addiction recovery, psychotherapy. People go into rehab or depending, they do outpatient, they just get psychotherapy. And we can't take that out. Addiction, TMS is not first line. We need to emphasize that. Sometimes people come in for consider TMS as an option if there has been frequent relapses, or someone has gone into a treatment and then they were doing well, they had a relapse, they've had second, third relapse, and say, okay, consider this. But again, we can't remove patient factor. Someone might have the financial capacity to say, you know what, okay, while we get psychotherapy, while we get this, the other therapy, can we do TMS side by side? You would not tell them no. So that's, I think that answers that question. I know Dr. Abdullah might want to add to it. I didn't particularly get the second question. I don't know if you could come again.
Okay, that's the second part of the question, right? Okay,
Yes,
let me read
yes.
your question out again. At what stage of addiction should TMS be considered as a treatment option? And are there, I think this is the second part you're asking, and are there particular drugs of addiction that TMS is more effective in treating than others?
Okay. Yeah, I think that there is no particular, it all depends on the studies that have been done with regards to that particular substance. Because essentially it's almost the same pathway, the mesolimbic dopaminergic pathway, and all of, like Dr. Abdullah was saying, the dorsolateral prefrontal cortex, that relationship, that the same pathway, that addiction tends to follow the same pathway. So it now depends on the studies that have been done. For nicotine, for example, studies have been done. For alcohol, studies have been done. For cocaine, studies have been done. So we cannot conclusively say that TMS is more effective in cocaine than it is for alcohol and for this. I mean, in this part of the world where we have a lot of over-the-counter prescription being abused and where people use codeine, how much, and we know codeine is an opioid and all of that, but how much studies have been done to assess the impact of this on this? So instead of individualizing it, because they follow the same pathway, it is potentially impactful. Thank you very much. I know Dr. Loretta's hand is up, but I know Dr. Abdullah too would want to add to this.
Okay, thank you there, Dr. Williams. Dr. Abdullah, would you want to speak to this before Loretta?
All right. Thank you very much. I really want us to understand that TMS in the context of addiction, as far as is concerned, we are talking about it as an adjuvant. When we say adjuvant, that is, if this current treatment we have for combine it to get better, we are not looking
Yeah, Dr. Abdullah, I think we lost you there. Your network is
Yeah, I
something.
think it's off. I think
Yes. Oh,
his network is problematic. But Dr. Loretta's
okay. I
hand is
think
up.
yes. Okay, so we can take Loretta. Loretta, go ahead, please.
Thank you, Dr. Babafemi. This is just an addendum to what Dr. Williams and Dr. Abdullah has mentioned. And like I'd asked Dr. Williams to confirm to me that in as part of the package for TMS, that they also consider medication assisted
Hello, are we together?
therapy.
Yeah, we lost you there, Dr. Abdullah. So while you were away, we quickly brought
I
in
think Dr.
Loretta.
Abdullah should go ahead. I think Dr. Abdullah should go ahead. I could just jump in.
Okay, Dr. Abdullah, so you can go ahead now, please. You can conclude. You can learn properly now, Dr. Abdullah.
Oh, all right. So what I was saying was what? TMS, we are looking at it as an adjuvant. So there is no particular stage where you say, okay, this is when I want to bring in TMS. As long as TMS are available, the patient can afford. What we are saying is if you combine normal therapy, psychotherapeutic intervention we do currently, you are likely going to have a better outcome. That is what it means. The services are available and the person can afford. It will do that person a lot good to combine your traditional psychotherapeutic intervention with TMS at any stage.
All right. Thank you very much.
So
okay.
Whether there is differential reason for different drugs. No. If you look at the intervention just targets the areas of the brain that is responsible for this addictive process, and all the drugs follow the same pathway. It is basically the same any kind of addiction. All right.
All right.
And that is why there are trials currently ongoing to see if it is going to be effective in management of gambling and other forms of addiction. And the results are really exciting. Thank you very much.
All right, thank you there, Dr. Abdullah and Dr. Williams. I'd like to ask this question from Neta in closing. Please,
Sorry,
when we
Dr.
respond...
Can I just say something, if it's okay? I just wanted Dr. Abdullah to just mention that. And I was hoping that...
Okay. What if it is not okay, Loretta?
I'm sorry, I will just drop the mic. I'll drop it. Thank you.
Go ahead, Loretta. You know you like to drag me. So that's why every opportunity I see, I also give it back to you. Go ahead.
I really apologize for jumping in without being asked to. I apologize. I just wanted to say that I'm hoping that Dr. Abdullah and Dr. Bukola can actually specify the alongside treatment or therapy. Like I had mentioned, the medication the medication assisted therapy and the cognitive behavioral therapy. Are those two things, are those two therapies part of what is being utilized alongside the TMS for people with people with substance use disorder? And if that is it, then what kind of MAT is being used, so people can actually know that? With TMS, yes, and Dr. Abdullah said it's an adjunct. I completely agree. It's not a first line, but why don't we just be explicit to say that this is what we do? The MAT is there, the CBT is there. When you just say psychotherapy, people might not really understand. So you can just explain that you go through this 1 or 2, 3 processes, and if this actually doesn't work, we could just introduce this to reduce craving. But basically, TMS is primarily for depression and OCD. I would really appreciate if we really break it down. I know today is a medical day for all the medical doctors. I'm excited to listen and to be part. But can we just talk about the MAT, if you're using MAT, the CBT, and other therapy you're working with alongside with TMS for people with substance use disorder or whatever form of addiction, so people can be clear about it. Yeah, thank you.
All right, over to you, Dr. Williams and Dr. Abdullah.
Yeah, like we've said, we do MAT, that's medication-assisted therapy. We do CBT. We do. It's a complete package, Dr. Loretta. Here, it's a right from the entry assessment. The assessment is quite very It's a huge one. Like I was training a few people today, and I said to them, I mean, if you get your assessment right, you'll be able to provide your individualized treatment plan. If you get your psychosocial history correct, you get everything right, you'll be able to provide your ITP and all of that. So it's a complete package. Focus is not on TMS. If you come, I mean, you get CBT, for depression. You can use CBT for practically everything. You get anger management. You go through assertiveness training, relapse prevention, coping strategy. I mean, it's a complete. You go through the 12-step program. You have group sessions, individual sessions, and you have homogeneous groups for people with similar problems. You have heterogeneous groups of people. I mean, and so it's a complete package, Doc. And we are stating again that RTMS is an adjunct in treatment. It's not first line. It's not first line. And that conversation would usually come up between the team and the patient at what point RTMS can come. And patient's consent is quite very important. I hope I clarified.
We did a great one, Dr. Bukola. Why I'm saying we should reiterate it is because of listeners, and I'm happy you've done that. So people, I'm sorry, I'm just being repetitive, and it's deliberate. So people can know that once you have a family member, friend, colleague that's having substance use disorder, please, the first place you go to is not for TMS. The first place you go to your primary care doctor, physician, and let them walk you through the first line before you begin to consider TMS. People, that's what I'm just saying. TMS is not the first thing you do when you have someone close or you want to recommend someone close for substance use disorder treatment. TMS is not the first line. But however, it could be the first line for depression and OCD. But please, for substance use disorder, it is not. Thank you.
Thank you very much.
Before the blogs say what we didn't say. Thank you for emphasizing. Before the blogs carry us and say what we didn't say.
Loretta really has all the time for us for this conversation today. Thank you, Loretta. I would like to ask this. I was asking this when there was an interruption. I think it's going to be my last question, and Dr. Williams would respond to it and then add it to his closing remarks. Then Dr. Abdullah will do the same, and that is coming from Neta. Can one continue antidepressant drugs while on TMS treatment? Let's take that along with our closing remarks, gentlemen. Thank you. Please go ahead, Dr. Williams.
Thank you, Dr. Femi, sir. Yes, you can continue your antidepressant while on TMS. In fact, it has a tendency efficacy to give you better efficacy. And so on that note, thank you so much for having us. I love to talk about two things. I love to talk about TMS. I also love to talk about adult ADHD. And maybe that's one thing we'll look at another day. The connection between ADHD and substance abuse is quite very enormous. About 25 to 50% of people who have ADHD will also have an addiction problem statistically. Thank you very much for having us, and look forward to being here again. Thank you, sir. And thank you to everyone who is listening.
All right, thank you very much there, Dr. Williams. Doctor, before I do the final vote of thanks to both of you and everybody, Dr. Abdullah, would you like to have your closing remarks?
Yeah, thank you very much to everyone for supporting this conversation. And we hope to have more people join the conversation. And like I always say, we hope to see people who partake in this conversation, take it to their communities, to their streets, to their churches, their mosques, and enlighten people who were not fortunate to be part of the conversation. That is the essence. And I believe together we can win the war against substance use. Thank you once again.
All right, thank you very much. On that note, I'd like to speak to something Loretta started with based on just drawing from what Dr. Abdullah has just said. We have every week we did have quite a lot of media houses represented on this platform because they want to learn as well. That is journalists, they want to learn and also want to share these facts, this information, this knowledge, also with other members of the public who may not have the opportunity to be online to be with us. And that's why we keep saying that it's a recorded conversation and anybody can go back to it. It's only when, so it's a public platform, and it's only when we are misrepresented or misquoted that then we can kick against that. So I'd like to enjoin Loretta, please, to take this as just a public service. I'm sure you'll be glad when somebody reads some of your views from the knowledge you share here and they read elsewhere, is just to try and as much as possible to create multiple platforms to share facts and knowledge about, that we share here, so that more people, a wider number of people can get access to this information. And that way we're trying to help them, we're trying to raise awareness, and we're also trying to save lives and ultimately humanity. So please, Loretta, let's take that. We can continue the conversation in our DM, Loretta. I know you have all the time. We can continue the conversation since you have unfettered access to me, and I do, and vice versa. Okay. On that note, I once again like to appreciate our guest today, Dr. Bukola Williams, a mental health physician and TMS specialist. Today we've been speaking on efficacy of transcranial magnetic stimulation in drug addiction and mental health treatment. And we've also had Dr. Abdullahi of the Ahmadu Bello University teaching assistant. In fact, until this topic came up and Dr. Williams came up, I never actually knew that even Dr. Abdullahi, that has been with us for quite a while, also is versatile in this area. Thank you very much to both of you gentlemen. I would also like to appreciate our own Dr. Loretta, who joined us from Chicago, Illinois. Thank you, Loretta, for always very consistent. We appreciate your contributions, especially today. Today, so Loretta, I'll tell you, is you deserve an award for that. I'll come back to you on that because Loretta would always like to do 30 minutes, 1 hour, and disappear. But today she spent she's with us all through the program. I can understand how tight her schedule is over there, especially because of the time difference. Thank you very much. I'd also like to appreciate another of our medical personnel who is always quiet but then always consistent. That is Tinika. Tinika, I know Tinika is joining us from Chicago, Illinois. Thank you very much, Tinika. We appreciate Oshino Bioluwa Femi, Muhammad Bafo, our own quiet member, also John Ogunjimi, always present but quiet, even though he comes in once in a while. Abiola JP, Perpetua Anabdi, Manuel, I appreciate Perpetua Anabdi. Perpetua Anabdi is also another vocal member of the platform. Thank you, Perpetua. Kerry Obi, Ibrahim Mayo, Demo, Dr. Dimeji. Dr. Dimeji is a new officer of the agency. Thank you. I also see Neta. Neta has also been very active. Neta is also a young officer of the agency, including Ibitoye. Ibito is another young officer of the agency. City Boy at City of Mogbala, thank you. Youth Action Network on Substance Abuse, thank you. Regina Ejegeri. Alessandra, Jafar, and including my own patriotic patriot. Thank you to all of you for being part of this conversation today. Please, like you said, note that this conversation is recorded and it's available on social media handles, especially at NDLE01 on Facebook and at NDLE_Nigeria on YouTube, as well as on X Space. Before I go, let me again thank some of my colleagues who have been working behind the scenes supporting me here. That's Shidi Musa, Francis, Dele Mahmoud, Blessing, Kumbi, Vina, Charity, Phil, Val, John, Ima, Ali, and a whole lot of you. I appreciate you guys. Thank you for doing this with me every week. God bless you all. Please, this is Friday. I know the urge to go out there and relax and enjoy yourself. Let's take it easy. Let's take let's take the advice from our experts. Please avoid those drinks that will make you lose control of your mental faculty, your of your decision-making processes. Avoid illicit substances in one word. Thank you very much for the day. And next Friday definitely is another time for us to continue the conversation. Have a good evening. While I hand you over to my colleague. Okay, Mahmoud is around. Please, Mahmoud, go ahead and let's call it a day at this point. Bye-bye.
Thank you very much, sir, and of course the host for taking us throughout today's program. For more information, like he said, our listeners can visit our website www.ndlea.gov.ng and perhaps our social media platforms at ndla_Nigeria on Instagram, Twitter, and YouTube. On Facebook, it is at ndlea01. Do join us same time next week for another edition of this wonderful program. I remain Mahmoud Isa, and over to you, Bamidele.
Even though it not to me, even to my body, even though it not by me, it don't buy somebody, even though you never, even though you want to, I'm really no bother, they go on do you, even though you didn't know, now you know. Drug abuse battle, even though it don't do me, even do my body, even though it don't buy me, it don't buy somebody, even though you never, even though you want to, I'm begging no bother, big old wound to you, even though you didn't know, now you know, drug abuse battle. Don't do them lie, don't do them no lie, don't do my heart. Even though you know be a drug addict, be your part to make. I next for no carry them.